Hello everyone. This is rather awkward. I'm speaking to my computer, but my name is Myriam Farah. I'm a nephrologist here at St. Paul's Hospital, practicing out of Vancouver. Thank you very much for spending your lunch hour here with us today. What I'm hoping to get you to is really an idea and an approach to acute kidney injury in your outpatient setting. And an understanding of some of the implications of care as well as future events for patients. So we'll get straight to the meat of the matter here. So at the end of today's talk, I hope to cover the following objectives. We should all be very comfortable in recognizing what constitutes acute kidney injury in the outpatient setting, who our patients are who are at risk for AKI. I will go through some initial steps in management that I would hope we can get going, initial investigations, and then really questions that we get often is when to know to refer a patient to a nephrologist or a urologist versus sending them to the emergency room. One thing I hope to really just briefly touch upon is really what a diagnosis of AKI means for a patient in terms of their future prognosis and how this sort of impacts management. So recognition of AKI has actually become much more standardized and easy over the last few years, owing to some very important research that's come out of the ICU setting as well as the hospitalized patient setting. We are essentially dealing with three markers of kidney function that we could look at when assessing kidney function numbers, but we have recognized that out of those three markers, the creatinine, specifically the creatinine change, is the most important variable that we can assess when trying to recognize AKI. Creatinine, as you know, is influenced by muscle mass as well as volume status and does undergo daily fluctuations of about 5 to, I would say even up to 5 to sort of 15 micromoles per liter. So it is important to know what our patient's baseline creatinine value is. Once we know what a patient's baseline creatinine value is, we would look for changes from that baseline in order to recognize acute kidney injury. And as you can see here, the definition of AKI is a very sensitive one. A rise of 26 micromoles per liter up from baseline technically constitutes AKI, and you might say, well, that's very sensitive. It doesn't take a lot to raise your creatinine by that little, and that's true. The whole point of this definition is to have a very sensitive variable that really captures more people that are actually going to be in deep trouble. The two other markers that are often assessed and evaluated when dealing with kidney function assessments are glomerular filtration rates as well as urine output. And the only thing I will say about those two is that they're really not all that helpful in assessing and recognizing AKI. GFR, as you know, is not measured but rather calculated. There are a bunch of other variables that go into the formula that spit out the GFR for us at the end of the day. But most importantly, GFR tends to lag severely behind changes in kidney function. In other words, a patient who is experiencing drastic changes in kidney function, which would be or can be the case when it's acute in nature, are not going to manifest GFR changes that are as drastic or severe in nature. So my recommendation is not to look at changes in GFR when dealing with acute changes in kidney function. And I should say that an acute change in kidney function is anything defined as anything that happens within 48 hours. By the same token, urine output is equally challenging or fraught with confounding variables when evaluating kidney function. It is actually extremely hard to stop peeing. So by the time our patients report anuria or lack of urine output, we are dealing with a very, very rapid and severe evolving process, or bilateral obstruction. So anuria in itself is helpful because it essentially means you should be sending that patient to the emergency room. But any sort of changes or lack of changes in urine output don't really mean anything. So in other words, you can have AKI and the patient might look you straight in the face and say, but I pee normally, which is something that you probably hear quite a bit. So GFR and urine output not helpful, creatinine the most helpful variable in recognition of AKI. Once you have recognized AKI, the initial workup and tests should be screening in nature and really should sort of accomplish two major goals. The first goal is to assess the severity of AKI and potential complications, which will then dictate your management. And the second is to try to at least point you into a direction in terms of what the cause of AKI is. So the recommended blood work, once you have identified by virtue of creatinine changes that you are dealing with an AKI, would include, of course, a creatinine and a BUN, but also electrolytes, sodium, potassium chloride, and bicarbonate, mostly because it's changes in these electrolytes that will dictate how urgent your management should be. The next step would then be to try to get a sense of what is causing the AKI. The absolute necessary investigations to order at this point would be a urinalysis, which should be ordered as a routine and a microscopic examination of the urine, a urine albumin to creatinine ratio, as well as a renal ultrasound. The urinalysis can be very helpful in either reassuring us that there's probably not something super worrisome going on, which often manifests as a very bland urinalysis. So these are the urinalyses where you might get a report of a hyaline cast, but really no RBCs, no WBCs, and no protein. If you see a urinalysis that has new or evolving RBCs as well as presence of protein, this is what we would call an active urine, and it is quite worrisome for a nephritic syndrome or an active glomerulonephritis, which again would dictate the urgency of diagnostic workup. If you do see white blood cells in the urine, it may or may not actually go along with an AKI, but it can point towards either an infectious or an allergic etiology of your AKI. The urine ACR, as you know, is a very helpful test in estimating 24-hour protein content if we were to do a 24-hour collection. A lot of my colleagues in the primary care field ask me whether 24-hour collections are even necessary anymore. And the answer is yes and no. As a screening test, it is not necessary to perform 24-hour urine collections unless the urine ACR is drastically abnormal. We know that urine ACRs are very good estimators of 24-hour urine protein collections, but really only up to a certain limit. We're accepting that below nephrotic range proteinuria, the ACR is an acceptable screening tool. But if you get an ACR back and the value that you get is something like 300, 400, or 500, that's when things get a little bit murky, and we would recommend proceeding with a 24-hour urine collection to get a better sense of the exact quantity of protein in the urine. So as a screening test, it's good unless it's very high, which usually is in the range of nephrotic range proteinuria. The renal ultrasound is necessary, and I say that because a lot of patients think that there is no way that they could be experiencing urinary obstruction if they're peeing normally or what they perceive as normal. And as you know, a urinary obstruction can cause a variety of changes in urine output, sometimes not change urine output at all. So the renal ultrasound really remains necessary. Tests that I do not, again, think they need initially include the 24-hour urine collection for reasons that we've covered, and CT scans. And the reason I say that is because getting CT scans is difficult timing-wise. It is exposure to radiation, and it may actually be unnecessary. The only time I would advise CT scans is if there is a high index of suspicion that we're actually dealing with obstruction, which may be intraluminal or extraluminal in nature. So patients with history of stones, for example, I would consider going straight to the CT KUB and skipping the ultrasound. But again, the ultrasound remains quicker to get in most senses and less of a risk to your patient. So who's actually at risk for acute kidney injury? It's really almost or nearly everyone that I see in my practice from all sort of walks of life and with a number of underlying medical conditions and even normal medical histories. So although there are certain patient populations that are at risk for acute kidney injury, including diabetics, hypertensive patients with underlying atherosclerotic burden, it is actually hard to pinpoint a specific population at risk because the etiologies of AKI are so varied. So let's talk about etiologies of AKI. As you may remember from your medical school days, we still, and I still think of causes of AKI in three major categories. I think of pre-renal AKI as anything that influences kidney function but is outside of the kidneys, so it is a measure of effective circulating volume and what the kidneys are actually perceiving. There's renal AKI, which basically boils down to intrinsic processes involving either one of the four major structural compartments of the kidney, including vascular, glomerular, tubular, or interstitial causes. And then we think of post-renal AKI as really anything that it forms an obstruction to urinary flow following exit from the renal pelvis or following exit from the collecting tubules. So again, pre-renal, renal, and post-renal, I still teach this to this day, and I still go through this approach every single patient that I see, both in the hospital and in the outpatient setting. So let's talk about causes of AKI and hone down on some of these specifics. So obstructive AKI, also known as post-renal AKI, is probably the easiest one to investigate. We tend to think of obstruction as being mechanical in nature, really something that's in our path or in the path of urinary flow, but we are recognizing that sometimes this obstruction is not really inside the collecting system, but can rather be caused by outside forces that are causing compression of that system. So I encourage you to think of obstruction as either intraluminal in nature, which could be on the basis of stones, tumors, abscesses, or clots, or extraluminal in nature, so anything around the collecting system that could be compressing down. Often we have expanding aortic aneurysms, so a blood vessel, lymph nodes, which can become numerous and enlarged in patients with lymphoma, retroperitoneal pathology or fibrosis on the same basis. Fluid, so a huge amount of fluid in the abdomen, whether that's really, really tense ascites, for example, can cause compression. And of course, any tumors or abscesses in the surrounding viscera can cause compression of our system. Do not forget that obstruction tends to be most often down at the bladder neck, especially in men, owing to problems related to their prostate, but we should not, and we often don't, forget about obstruction that is actually higher up, and again, can be anywhere along the course of the renal tubules down to the bladder neck insertion site. When it comes to obstruction, I think there are some helpful things to keep in mind. The most common causes of obstruction as an outpatient would be prostate enlargement in men, stones, urethral strictures or stenoses, or bladder outlet obstruction. From our experience and from our patients, we've learned that obstruction actually tends to be painless. By the time a patient is actually complaining of pain either on one or both sides of their flanks, and the cause is due to obstruction, we are most likely dealing with a concurrent process, which tends to be something like an infection or such huge capsular stretch of the renal capsule that it's manifesting at pain. Usual hydronephrosis is not going to be painful. Patients with a urinary obstruction are rarely anuric, again, unless the obstruction is down at the bladder neck and is complete in nature, so something that doesn't even let a trickle of urine go by, or if it's above the bladder, if it's bilateral in nature. And few things actually cause bilateral obstruction. It is much more common to see unilateral hydronephrosis than it is to see bilateral hydronephrosis, sorry, I've been dictating all morning. It is actually more common to see bilateral obstruction if we're dealing with extraluminal pathology than it is with intraluminal pathology. Now, one thing that I remember, and I just wanted to put up, we quote quite a bit in the textbooks, and residents still ask me about these days, is, well, if we have unilateral hydronephrosis, that can't possibly be the cause of their AKI, because we know that we should have another kidney, and we know that you really only need one kidney to maintain kidney function. And that is true to a certain degree, but it is often not true. And the reason for that is that patients who come to hospital or patients who present with hydronephrosis, it is rare that they have absolutely no other medical conditions. These are often patients who suffer from other medical conditions and may actually have underlying chronic kidney disease that's been somewhat compensated by the presence of two working kidneys. So as soon as you take that one kidney out of the equation, you can actually unmask underlying CKD in that other kidney, and you can definitely see changes in kidney function as a result. So unilateral hydronephrosis with a concurrent rise in creatinine, in my mind, are completely related and warrant intervention. So when we're looking for obstruction, the initial workup really includes starting with a screening ultrasound. If the ultrasound shows the presence of hydronephrosis and even might comment on the presence or suspicion of stones or tumors, my recommendation is to proceed with a CT-KUB. This CT-KUB is going to be more sensitive as well as specific in actually eluding what pathology we're dealing with. If you see hydronephrosis, chances are you would have done some blood work already, because it's what made you screen for hydronephrosis in the first place. But if you haven't, you should arrange for urgent electrolytes and a urinalysis. If you see that the blood work is abnormal in a sense that you have a creatinine that is elevated from the baseline values, in other words, there is a change in kidney function, but the electrolytes are within normal range, that patient needs to be referred to a urologist, and this can be done as an outpatient but should be urgent in nature. So I would encourage you to pick up the phone and refer to a urologist with a new diagnosis of hydronephrosis with a change in creatinine. If, on the other hand, you're detecting that not only your creatinine has risen, so you're dealing with an AKI, but you also have complications of that AKI, for example, hyperkalemia or acidosis, my recommendation would be to send this patient to the emergency room for a rapid assessment by both nephrology as well as urology in order to not only deal with the obstruction quickly, but also provide dialysis support if necessary. If, on the other hand, your ultrasound does not show hydronephrosis, but comments on other abnormalities, you may still pursue an outpatient referral to a urologist, but it is unlikely to be the cause of your AKI, especially if you're not seeing acute changes in hydronephrosis. So the moral of the story really is obstructive AKI is easy to detect. but it's unlikely to get better on its own. So if we wait too long, the obstruction often will cause severe electrolyte abnormalities if it's acute enough in nature. And if it doesn't do that, what actually happens is we tend to deal with patients who develop slow but progressive obstructive nephropathy. So my recommendation would be to get the imaging done as quickly as possible, send the patient to the ER if you're dealing with any severe electrolyte abnormalities, send the patient to the urologist if you're dealing with new hydronephrosis, but really sort of do this in an expedited manner, especially if you do see hydro. So pre-renal AKI is also a rather well, I should say not easy, but rather interesting challenge to pursue when you're looking for etiologies of AKI, because we often describe this as finding the needle in the haystack. Often, once you find that needle, it tends to be a rather large needle because it's so obvious when you sort of look back. But in order to get to a diagnosis of pre-renal AKI, you really have to be quite thorough. The reason for that is that there are a number of causes of pre-renal AKI. Essentially, how I think of pre-renal AKI is anything that is causing absolute or relative hypoperfusion to my kidneys. So that can include absolute extracirculating fluid loss, including losses of blood, vomit, GI secretions, and stool, or a relative change in extracellular fluid. So conditions like cardiorenal syndrome, hepatorenal syndrome, or any of the etiologies of shock can absolutely hypoperfuse the kidneys. What we call the deadly combination of ACE inhibitors and NSAIDs essentially work at exactly the right spots in the afferent and efferent arterioles to decrease GFR and therefore can cause pre-renal AKI. And then I've listed for you, for your knowledge, other things that can cause pre-renal AKI, but again, it's rather unlikely that you're going to be dealing with these in the outpatient setting. So aortic catastrophes, renal artery catastrophes, abdominal compartment syndrome, we tend to see these in the hospitalized patient, but not so much in the outpatient setting. So again, the most common causes of pre-renal AKI include either true fluid loss in the form of GI losses, or something that you probably see quite a bit, cardiorenal syndrome. So patients with underlying cardiac disease who have had either a change in heart function or a change in their medications, including diuretic readjustments that cause relative hypoperfusion of the kidney. The workup of pre-renal AKI is very similar to what we've talked about already. You're still dealing with getting your creatinine and BUN, your electrolytes, the urinalysis with the ACR, and the ultrasound. And most of that you're doing to exclude complications which would warrant sending a patient to the emergency room, but also to sort of exclude obstructive causes of AKI. Management of suspected pre-renal causes is really to stop any potential nephrotoxic agents, to make sure that you're renally dosing all the remaining medications your patient is on, and then try some simple maneuvers to try to improve renal perfusion. For example, if your patient is hypotensive or hypovolemic, it would make sense to re-evaluate their need for blood pressure medications, their fluid status, and even maybe replete them gently as an outpatient with salt and fluid repletion. If you're indeed dealing with pre-renal AKI and it's due to one of these things and you have intervened, you should see a response quite quickly. So the golden rule in AKI due to a pre-renal cause is that you should see an improvement by 24 to 48 hours of an intervention. If you do not, it is not pre-renal AKI, or it was, but you did the wrong thing. For example, if your patient was in heart failure, but you thought they were hypovolemic and gave them more fluid, well, yes, they were in pre-renal AKI, but unfortunately, the other one. So what we should have done is to optimize cardiac function rather than load them up with fluids. So it becomes very, very important to identify the correct cause of pre-renal AKI so that you can initiate the appropriate management, but most importantly, you should see an improvement in your kidney function by about 48 hours if your management was correct. Again, if any time during your management of pre-renal AKI you're detecting a serious electrolyte abnormality, so things like severe hyperkalemia or acidosis, I would recommend just dealing with that in the emergency room rather than in the outpatient setting. So once you have thought about obstructive AKI and ruled that out, thought about pre-renal AKI and undertaken some simple maneuvers to try to correct it and not seen correction, well then you're sort of left with looking for the intrinsic renal AKI etiology. And my colleagues and I often sort of think about this as the same thing as really looking for Waldo, because intrinsic renal AKI is a difficult pathology to pick up, and it's a difficult pathology to confirm without actually undertaking a renal biopsy. The types of intrinsic renal diseases that we deal with, and I'm sorry if that looks a little squished together there, are really concentrated to 4 major compartments of the nephron and things that can go wrong within each part of that compartment. So we have glomerular causes of intrinsic renal disease, tubular, interstitial, and vascular causes. It would take many, many lectures on their own to go through each one of these compartments and the associated pathologies that we can look for and detect. So what I'd like to do is to really just give you some helpful hints and kind of clues that you might be dealing with an intrinsic renal process. On history, which, you know, it all sort of comes back to in the end, you really should be probing for renal symptoms. So anytime you're detecting abnormally colored urine, whether it's pink, red, or grossly red or grossly bloody in nature, frothy urine, or new onset edema, this would suggest a potential nephritic or nephrotic process. Equally, the new onset of hypertension, as you know, is a clue that we might be dealing with nephritic syndrome. It shouldn't be ignored. The next thing on history to really try to tease out is to look for any sort of weird and wonderful funny things on history. So this would include a complete autoimmune and constitutional screen, looking for autoimmune conditions that could have an intrinsic renal pathology associated with it, or malignant conditions that can have an associated intrinsic renal process. And there's really no way of telling you how to screen for that, because by now you probably have your own process of going through sort of a review of systems. But really what I'm sort of tweaked by, our interest in intrinsic renal disease is tweaked by the following things that include B symptoms, rashes, bruises, ulcers, and photosensitivity that might suggest underlying lupus or RA, sinus problems, shortness of breath, chronic coughs, hemoptysis, chest pain. These can go along with pulmonary renal syndromes, joint pains and swelling, which tend to go along with the arthritides or, again, lupus, back pain or bone pain, which may or may not be related to underlying myeloma or, again, malignancy. And then changes in bowel habits, which again are a constitutional screen, but it can also be seen in vasculitides, which involve the GI tract. So however you're used to doing a review of symptoms, as long as you're looking for these things, it's helpful to know if any of these things have occurred concurrent with the AKI, as they're often linked together. The history should also be looking for any new medications which may or may not be causing an allergic reaction, for example, and then really risk factors for viral disease, which can sometimes go along with intrinsic renal processes. Your physical examination, in addition to what you would normally look for, should really look for specific signs of an underlying autoimmune or or malignant process. So I've put a few up there, but this list is of course not exhaustive. Anytime I see a patient with new swollen joints, rashes, purpura, edema, it does make me think of an underlying autoimmune process, and I'm much more quickly to pull the trigger on linking that together with an AKI. You can see that the workup, your initial workup, is very, very similar to what you've been doing so far, but it doesn't stop here, and that's really what the difference is. The further workup of intrinsic renal disease really depends on what you find on history, what our index of suspicion is, and how quickly we need to get things done. And although you can sort of be a shotgun approach and throw the book at them and just order all of these things, I actually don't mind if you call us, get us on the phone and say, listen, this is what I have. I've ruled out obstructive AKI. I've looked for the pre-renal. These are my patient's symptoms. I'm worried about this, or I'm at a loss. Where do you think we can go next? And we can definitely guide you in terms of ordering further blood work and how quickly to get that done. And then ultimately we can guide you on, maybe getting that patient in to see us a bit quicker, whether that's in the hospital or in the office setting. And we can definitely work together on making this more efficient. Intrinsic renal diseases, as I said, would require their own lectures in terms of getting to talk about the specific etiologies, but I do want to just draw your attention to the fact that the four major compartments of the nephron, so the glomerulus, the interstitium, the tubules, and the vascular system, can have a variety of insults, some of which are related to medications, some of which are related to underlying diseases, and some of which are just new autoimmune conditions that are evolving. So rather than to guess, what we often do is do a complete history, rule out obstructive causes, rule out pre-renal causes, order a bunch of investigations that I've listed for you here, but ultimately we might actually have to undertake a kidney biopsy because it's going to definitively tell us what exactly we're dealing with, what the severity is, and then definitely can guide our further management. So I think I'll leave it at that for sort of teasing out etiologies of AKI and just draw your attention to the fact that we used to think that patients who have developed an AKI and get better just sort of get back up, walk it off, and really don't have to worry about this again in the future. But a lot of the research and our experience with AKI episodes have taught us differently. We now know that once a patient has developed AKI, even if they have complete recovery from their AKI, they are at risk of developing recurrent AKI, of developing CKD or progressing their underlying CKD, of developing end-stage renal disease, and of actually dying. And that's not to say that every patient who has an AKI is going to die. That's not at all what I mean to relay. But we know that patients who develop AKI do so for a reason. And often those reasons, so the things that led them to develop that AKI, also have negative effects on overall medical health. So we need to be aware that a diagnosis of AKI is something that should really follow them around, because it makes me a little bit more nervous about that patient. It makes me extra vigilant in making sure that I avoid nephrotoxins, that I renally dose my medications, and that I'm aware that this patient has had AKI and things can go wrong with this patient should something else come along. So although I don't really advise that, we go around and tell our patients, well, your creatinine went up by 30 points, so that means you're going to die. I do think that it is something that should sort of stay in the back of our minds, because it helps us be more vigilant in the future. And the corollary that I draw from this is, have you ever noticed that once your patient is labeled with congestive heart failure once, it forever follows them around. It's on every single discharge summary. It's everywhere in their history. Even if their most recent echo is 65% ejection fraction, it's so hard to get rid of that label. I sort of envision that for AKI, and I might be regretting these words, but I do wish at this point that we over-report and over-document AKI than under-report, because it is something that is a signal. It tells you something about that patient and their comorbid conditions, and I definitely do think that it does have long-term complications. So, in summary, we talked about the definition of AKI, which roughly speaking, if you're going to remember one number, it's 25. So if your creatinine rises by more than 25 points, you are dealing with an AKI. The recommendations would be to quickly exclude post-renal causes by doing a history and an ultrasound and looking for signs of obstruction. I would then advise looking for pre-renal AKI etiologies and trying to reverse those etiologies. If your management and your assessment of pre-renal AKI and the subsequent intervention fails to elicit a response, in other words, your kidney function continues to deteriorate or not get better despite everything you've done, I would actually recommend you pick up the phone and you get us on the line, and we'll talk together about how quickly we need to initiate further investigations, how to sort of make sure that they're safe in the meantime, and then really sort of to guide your initial workup and management of that patient. So there is no treatment of AKI unless we're really dealing with intrinsic renal causes, which can sometimes be treated with immunosuppressive therapy. There is really no specific drug that I can throw at AKI and say, get better. So really the best treatment of it is to prevent it in the first place if you can. And hopefully we can work together in making that happen. So with that, I'll end the talk, and I'm more than happy to answer any questions, concerns, things that have come up, and we can discuss together. Good, very quiet group. Okay. Imagine I have to type it in. I'm trying to tell them. Okay, I am being told that if you have any questions, you would have to type it into your questions section, That's a very quiet group. Okay, well, there we go.
So my first question is, do you really expect family physicians to order that battery of tests every time they think the AKI is intrinsic? Wouldn't it be better to just refer urgently?
Yeah, absolutely. I think if I wasn't clear, this is the battery of tests that, sorry, did everyone catch the question?
I hope so.
Okay, so the question was, do you really expect family doctors to order all these investigations if they suspect intrinsic renal disease? Isn't it just better to refer urgently? And absolutely. I think that rather than sort of throwing the book at your patient, I would prefer if you get us on the line. Refer to us, call us, tell us what you're thinking and what you're suspecting. And what we'll actually do is we'll see your patient urgently. There's no question about that. But we can also sort of expedite that initial workup so that by the time we see your patients the next day or the following day, they've already had some of these investigations and we can evaluate them in that context. So absolutely, I wouldn't expect you to sort of throw all of these at your patients. Please call us and please refer to us if you're suspecting intrinsic renal disease. Sure. We'll just give you a few more minutes, and if any more questions come up, please shoot them our way.
Okay. If you suspect a post-renal AKI, how long do you wait to repeat the creatinine after the ultrasound has been ordered?
Okay, so the question is, if you suspect a post-renal AKI, how long do you wait to reorder a creatinine once the ultrasound has been ordered? I'm just going to rephrase your question a little bit. If you suspect a post-renal AKI and you have an ultrasound report that shows you obstruction, or in other words, hydronephrosis, it really depends on what you're going to do about that hydronephrosis and who's going to do it for you. So, in other words, if you're sending your patient to the urologist because of a new finding of hydronephrosis and a change in kidney function, until that urologist does something, I wouldn't expect the creatinine to get better. In fact, it could get worse, and your patient might actually develop electrolyte abnormalities while waiting. And so in your discussion with the urologist, because remember, if you're picking up new hydro and a change in creatinine, you should really be on the phone with the urologist. In your discussion with that urologist, you want to get a sense of when they can see your patient. My colleagues in the urology department will often guide you to get a CT-KUB done as an outpatient and then see the patient quickly within the week or so. While you're waiting and while nothing is being done, I would recommend at least blood work twice or 3 times a week in the absence of electrolyte abnormalities. However, all of this goes out the window if you have obstructive AKI and already have identified electrolyte abnormalities such as hyperkalemia and acidosis. If you're seeing those, I would recommend not doing any further outpatient blood work, but just sending the patient straight to the emergency room for inpatient management.
Here's another one. Post-nephrectomy, what is expected increased creatinine, and is there an increase when to expect return to return to baseline?
Wow, excellent question, and a little bit off the AKI topic, but very close to my heart. So the question is, post-nephrectomy, so after one kidney comes out, for whatever reason, I'm assuming whether that's an RCC or a tumor or something else, what are the changes in creatinine that you would expect following that? And the answer to your question is it's almost impossible to answer that question because it really depends on who your patient is, who's getting that nephrectomy done. One of the variables that would influence how much their kidney function changes is their underlying kidney function, their risk of underlying chronic kidney disease, their comorbid conditions, and really the ability of that other kidney to pick up the slack. So, as you know, for example, the easiest person to sort of use as an example is the healthy kidney donor who undergoes a nephrectomy. So, patients who donate kidneys are frequently known to have rises in their creatinine, which may or may not go back to baseline values. Often they don't, but still maintain relatively preserved GFRs and kidney function. But, and the big but is, kidney donors are very, very healthy people. They have been screened for a number of comorbid conditions. They are essentially as healthy as you can be in being free of things like diabetes and severe hypertension. They tend to be younger in age. They've gone through the hoops to be able to donate a kidney. So we wouldn't really expect there to be much in the way of CKD. So these people have an amazing ability to actually maintain relatively normal kidney function once undergoing a nephrectomy. Compare that to the other extreme example would be someone with a number of comorbid conditions, diabetes, hypertension, perhaps even cardiac disease on many medications, who now develops, let's see, renal cell carcinoma and has to go through a nephrectomy. the changes in kidney function in that person are going to be much more difficult to predict, only because we expect that they may have had underlying CKD to begin with, which may now be unmasked.
I have one more. Aside from NSAIDs and ACE inhibitors, can you give some other common examples of medications that can cause AKI? For example, those that may be dosed inappropriately for CKD patients.
Yes, absolutely. So, so there's a difference between medications that cause AKI and medications that are toxic when AKI is present. So things that cause AKI, like we talked about the NSAIDs and the ACE inhibitors or ARBs, those two would fall into the pre-renal category. Other medications which can cause an AKI would be things like antibiotics. So exposure to, for example, ciprofloxacin, Septra, penicillin-based antibiotics can give you an AKI because they manifest as an allergic reaction in the kidney, which we name acute interstitial nephritis. So if at any point you've started one of these medications and you see a rise in creatinine a few days later, there's a chance that they are having an allergic interstitial nephritis to that antibiotic. So antibiotics is definitely one that you should keep in mind. And then other things which you may or may not be necessarily prescribing, but other specialists involved in your patient's care maybe, some of the antimicrobials like gentamicin as well as amphotericin B. Chemotherapy, which again would be not prescribed by you, but perhaps monitored or managed by you, and then antiretroviral therapies. Those three can give actual tubular toxicity, which we see in the form of acute tubular necrosis. So most often it's an antibiotic, an antimicrobial, an antiretroviral, or some form of chemotherapy.
I think that seems to be nobody's good. Jumping down. So.
Great. Well, thank you very much for spending your lunch hour with me, and if you have any questions, please feel free to contact us. I'm hoping that all our contact information is in the material that you've been given, and look for that AKI. Thank you.